Well, thank you, Dr. Goldenberg, and it's a pleasure to be here speaking to a urology audience. I consider it a milestone to be invited by a urology group as a visiting professor as opposed to a radiology group. So, what I hope to do this morning is maybe just give you an overview of where the state of the art is with MR and prostate cancer, what we're doing at the centers in Toronto, and I'll get through as much as I can in the next 50 minutes or so. I would say that when I started in this field back in around 2000, that it was an area that I say myself as a radiologist I didn't know much about. Radiologists are usually involved with the assessment of advanced disease in prostate cancer. I certainly became aware of a very wide variation in therapeutic options for patients, and really a wide variation in biopsy practice. I think here and certainly in Toronto, at the major teaching centers, some of them the radiologists do the biopsies, others not, others it's a mix. But I learned that this primarily sits in the field of the urologist to do the biopsy. But certainly as got into it more, saw a wide variation in practice in the number of cores being obtained with biopsy, core locations, and how these schemes are done, drift in these numbers and approaches. And so that was the status when I came in. And then as I learned more about the clinical context, it became clear that really there's an overtreatment issue, and this is something I don't have to tell you guys. You're all familiar with this in the PSA screening era. And so we need more specificity. We need ways of predicting who the patients are, who have bad outcomes, and we need to do this on an individual basis. So we need to segregate for each individual patient the low-risk disease from the lethal disease. And I think this bears sort of emphasizing and repeating before we get into a lot of technology and a lot of discussion of the finer points, is that we have to keep our eye on the ball in terms of what we want to achieve with these technologies. Certainly there's another side to this. There's the diagnostic side, and then there's the therapeutic side. And a lot of work continues to be done on ways of reducing these sort of morbidity profiles or quality of life profiles from current radical approaches to treatment. And they go hand in hand. So imaging, in terms of better diagnosis and localization, and the requirements for that go hand in hand with the therapeutic approaches being advocated and put forward by the community. And this helps direct the quality of imaging, the performance measures in imaging that we want to achieve. And so it's important, I learned that as well, is that it's important to keep that in mind. You need to design the instrument to work with the therapeutic approach being used in the community. So what is the current trust biopsy paradigm, and how is it performing? Well, we know that Gleason score is the single best independent prognostic factor for prostate cancer. To assess Gleason score, we're using biopsy, but we have a significant undergrading problem with this approach, and this fundamentally boils down to a sampling problem, getting the needle in the right place, identifying the right lesion. And I think there's an increasing awareness and concern about urosepsis with the transrectal approach being used currently, and antibiotic-resistant bacteria. And I think this is something that we certainly see referrals for MR coming in more and more. Many of them physicians are people who work in hospitals who've had bad episodes of urosepsis and don't want to undergo another biopsy without targeting or without an absolute need. So what are the game changers? We need a better prognostic marker of lethal disease than PSA. This doesn't necessarily have to be imaging, but in terms of thinking about imaging, it would be really, really important if we could predict Gleason grade. It's not just about finding the cancer, it's about finding the high grade or the lethal cancer. And we need better localization. And if we can achieve both of these with an imaging technique, then I think we're on the right path. So what's changed? I mean, MR has been around since the 80s in Vancouver and Toronto, maybe since just the last few years. We're always running behind in Canada. But we've certainly had T2 weighted imaging for decades now. And there's been lots of work published on this with MR. there was then a lot of work published on proton spectroscopy, which is another MR technique. I will tell you that these never made it. These never made it into the multi-center environment, never folded into clinical care. And there's been two additional techniques that I think are the game changers for this. One is called diffusion-weighted imaging, and the other is dynamic contrast enhanced MR. And I'm going to show you some of the data on this. And these are all developed from brain techniques that were used in stroke and tumor assessment in neurological applications. And in fact, one of my collaborators in Toronto is a neuroradiologist. We translate a lot of those brain techniques to prostate. So here's data published in 2010 from the NIH showing the probability of tumor on whole mount as a function of the combination of pulse sequences used or imaging techniques used. And what you see is as we add more of these parameters to the assessment, or this multi-parametric approach, with the far right being T2 combined with a contrast-enhanced scan combined with spectroscopy, that we achieve sensitivities in the 0.8 range, 80% range. So this is where we want to be for this diagnostic test, is around an 80% number for tumors. And so where are we going to use imaging in the current then detection assessment in prostate cancer? And where I see this really coming in is at the time of biopsy, especially patients who are beyond their first biopsy, and that's for economic reasons, and really in the better stratification and identification of patients who may or may not have insignificant cancer, with the idea of potentially translating this then into selection for less morbid treatments. And so these bluish arrows, I think, indicate where the hot points are for the application of a roadmap identification technique with imaging and prognostication technique for imaging in the current paradigm of prostate cancer care. So in speaking with the residents yesterday, I think it's very important that urologists start to become familiar with MR as a modality. It's something that you really don't see much of in your training, and it's something new. And so when we're talking about these techniques, what are we talking about? So the first is dynamic contrast enhanced MR, and in this we inject a contrast agent, gadolinium, standard gadolinium contrast agent, but we image very rapidly through the prostate. So we're imaging the prostate every 5 seconds, and we get this movie of the contrast enhancement in the gland. And cancers, as they do in the breast, behave differently in the prostate than normal peripheral zone tissue. And so we're looking at about 5-second temporal resolution. And so the video here on your left shows you a cancer. And I'm going to show you two things on this video. The first is the transition zone here is very hard to interpret with this technique. The BPH nodules all light up. We can't distinguish them from cancer with this technique very well. But the peripheral zone cancers, and here it is, here's the peripheral zone cancer, lights up early with this. So this is the cancer, lights up early, washes out more than the normal peripheral zone tissue. And that manifests itself as a bright spot on the very early scans, in this case in the patient's left peripheral zone. And so that helps us in identifying where the tumors are in the prostate. And data published on this now back in I think this was about 2006, compared T2 weighted imaging to perfusion imaging, or this dynamic contrast, and it's showing again about a 80% performance, sensitivity, specificity, and accuracy for peripheral zone tumors with dynamic contrast enhanced MR. And this is a technique that just about every scanner in any practice can do. The temporal resolutions vary, but it's something available. MRS is expensive, add-on to systems. Most departments are not doing it regularly, and so it has accessibility. We then actually published work in 2007, and this came from earlier work from the UK and UCSF on diffusion-weighted imaging in the prostate. And we did one of the first whole-mount trials of this with John Trachtenberg and our pathologists. And what we showed is that, in fact, diffusion-weighted imaging gave us very good numbers here for sensitivity and specificity, while maintaining actually good positive predictive values. And this was a whole-mount correlation study, so optimistic results because all those patients have cancer. But this is held up, and so this is a recently published meta-analysis from 19 publications showing a area under the ROC curve of 0.85 for diffusion-weighted imaging compared to 0.75 and 0.79 for DCE. And this was statistically significant. Diffusion-weighted imaging performed better than T2. DCE and T2 were equivalent. So in fact, this has now been, I think, published in a number of papers and been shown in our work as well, that diffusion-weighted imaging is the single best incremental add-on to T2-weighted imaging for diagnosis. And I believe the radiology department here is focusing on T2 and diffusion-weighted imaging for their prostate cancer localization. But there's a bonus for this, and this is true of spectroscopy too, but again, spectroscopy is harder to perform. And this work has now been published by two groups. This is the Nijmegen group in the Netherlands, and the group at NIH has published this as well. And so on the x-axis here you have Gleason score. On the y-axis you have the ADC value. The ADC value is derived from the diffusion-weighted image. It's something called the apparent diffusion coefficient. And what you see here is that the ADC gets lower as the Gleason score gets higher. And yes, there's a lot of variability, a lot of overlap, but I will tell you that this is working pretty well. And this is a ROC curve with the threshold that they used in their patients here, showing an AUC of 0.94, predicting Gleason score greater than 6. So I'm using this in clinical practice. It works relatively well, and something that the urologists and radiation oncologists have welcomed as part of the assessment. So where we are today is really using T2 and then diffusion-weighted imaging. We still do dynamic contrast enhanced MR. It's helpful, I think, in select cases, but we've dumped spectroscopy. So let's now look at some cases. So here's a patient, and I'll go through a little bit of anatomy because we don't have primarily a radiology audience here. So this is an axial image. This is the endorectal coil that we use. Now we don't use this in all patients now. We moved away from this on 3T imaging. The peripheral zone is this bright stuff here, sort of C-shaped, I guess with Movember coming, we'll call this mustache-shaped area of the prostate. This is a little prostatic utricle cyst. Left ejaculatory duct, right ejaculatory duct. This is the cleavage plane of the old surgical capsule, if you want to call it. But and then these are transition zone nodules. This is the verumontanum here. This arrow-shaped thing is the look of the urethra when you're cutting through the verumontanum. This dark little triangle here and a little bit on that side is the anterior fibromuscular stroma. These are part of the ligaments, retropubic ligaments, or puboprostatic ligaments, and some retropubic veins here. The neurovascular bundles are these little dots in here. We don't see the nerves. We see the little veins actually around here posteriorly. So these little dots are part of the neurovascular bundle. And then this is the prostatic margin. We see this best in the midgland, in the apex, and base is a little more challenging to interpret. So that's some anatomy. Cancers will look dark. So is this a cancer? Is this a cancer? Is this wispy stuff here cancer? How do I tell? So this is an ADC map. So this is derived from the diffusion-weighted image. And remember, the lower the ADC, the higher the Gleason score. I will tell you that, so what we see here is a nice, clearly identified black dot. Not hard to interpret, fairly straightforward. This is actually a relatively low ADC. And so we're concerned about Gleason score 7 components, but a very small focus, right? This is the contrast enhanced component. And if we didn't have the endorectal coil, I think this would be harder to see if we were especially doing this at 1.5T because it's a small lesion. But with the contrast, it really accentuates the lesion, makes it easy to see. We did a fan biopsy in this area, 3 cores using ultrasound. Got these from 3+4, and the size matches. The core is about 18 millimeters. In length, you'd expect with this size, which is about 4 millimeters, about 20% of the core positive, and that's what we got. This patient was biopsy negative before this MR. So this is an example of sort of a small lesion that we can target. Now, whether this Gleason, you call this Gleason upgrading or drift because we're sampling better, or whether this is really an indication that we need to treat this patient. It's another debate that we run into sometimes, but we certainly can do it now if we want to. So I think the next thing is really to develop an understanding of pathology. And I actually hit this point about 5 years ago in the work where I said, I don't understand the radiologic pathologic correlation here. This isn't like renal cell where the tumors grow like nice balls. Something's going on. I'm seeing weird things, cases where I'm missing cancers. I don't know why. Cases where there's big cancers on pathology that I don't see at all on imaging. So I need to understand this better. And even in terms of treatment, the big argument that was given when I started was, Masoom, you're wasting your time. Prostate cancer is multifocal disease. We need to treat the whole gland. And this is what I heard even from John, from Dr. Trachtenberg when I first started. He says, this is not something we should be doing. And he changed his mind very quickly. And I think we've seen a drift towards this idea of the index lesion. So what's some of the data on this? The average number of tumors per patient is just over 2. There's usually a dominant focus, and the size discrepancy between the dominant focus and the next focus is quite large. So you go from 2.4 cc's to about 4 times smaller at 0.6 cc's between the two. That means when we're looking at the imaging, chances are if the patient has cancer and it's clinically significant, we are going to see one lesion clearly, but we may not see the other lesions. And so that's important in terms of deciding how useful imaging is. Extraprostatic extension is usually from the dominant focus as well, so in terms of that prognostic marker, that's important. And so we have more data coming in. Recent genetic studies are suggesting that in fact it is this dominant lesion that is the clonal tumor that produces metastasis, that it's not from multiple tumor sites within the prostate. And so as we move forward then we say, okay, what is the threshold? What do we need to detect with imaging? What is clinically significant disease, and how can we take this information and synthesize it into an imaging paradigm? So there's general consensus, I think, that if you have Gleason 4+3 disease or higher, that this is clinically significant. Something should be done if possible in this patient. I think there's general consensus on the other side that Gleason 6 disease, particularly less than half a cc, is not significant. And I think there's varying opinions on everything in between. So in asking how well MR is doing, or imaging is doing, we better not be missing the 4+3s, for sure. So let's look at a case now, and with some pathology. So here is a peripheral zone tumor, easily identified, low ADC, and actually the DCE MRI analysis shows slight increased permeability, but not so obvious here. But it shows a second lesion, and this is the value of the contrast enhanced component. When I go back, I say, yes, okay, there's a little triangle here at the periphery that matches this. And so this is a highly suspicious lesion, a definite lesion. This is a probable lesion. Let's look at the pathology. So when we look at the pathology, we see, yes, we identified 2 of the lesions in the peripheral zone, but we missed 3 others. Is that significant? I would argue no, that it doesn't matter that we missed the other 3, that the driver lesions are going to be probably the largest one, or at worst the next largest one, in terms of this patient's prognosis and outcome. So if we biopsy the larger one and get the Gleason score on that, I would argue we've done a big part of our job in terms of improving patient care. So let's look now. We now have multifocal disease, varying Gleason grades within the prostate. What is the performance when we start to get? So I showed you sensitivity and specificity numbers for all cancers in radical prostatectomy patients. What if we start to break this down? How's the data coming in for this? So here we have 3 papers, and what I've done here is I've picked the numbers at the lower end of the reported scale. You know how they, when you have multiple readers and they give you these scales. So I've tried to be conservative here and say, what is the sensitivity specificity for grade size dependent assessment? So for Gleason score 7 and less than half a cc, we're at 70 and 80. As we get to larger tumors, we do better. And certainly for tumors over a cc, Gleason 7, we're doing very well. There is not stratification in many of these studies for, I think, what's a very important question, is 3+4 versus 4+3. And so it'd be nice to see more data come out on our ability to tease those apart we're seeing a lot of biopsy samples with minimal 4, and this I think creates some question as to what to do with patients. So let's look now at another aspect of the radiologic pathologic assessment. So we talked about multifocality, Gleason score, and performance based on size and score. What about location? So when we look at the current biopsy paradigm, we see that 70% of the tumors we know occur in the peripheral zone and about 30% not. But our biopsy schemes are dominated by posterior gland assessment. And so what happens in patients, and this is one of the commonest indications for MR, high PSA, prior negative biopsy, or low-grade, low-risk disease, but rising PSA. Well, we see distributions of cancer that are, we'd expect. Now, some people think that this is related to these tumors being more aggressive, and they call this PEATS, or an evasive anterior tumor syndrome, is what Dr. Fleshner likes to call this. I think you can make a strong argument that these are just tumors that we just have repeatedly missed, and so we catch them late, but I don't know. And so let's say, well, I've talked about peripheral zone performance. What's the data on anterior tumors and transition zone performance? And the only purpose of this slide is to just show you that when you start to look at the histopathology in the transition zone, what you see is that you have carcinoma, stromal hyperplasia, and glandular hyperplasia. And what this is showing is that glandular hyperplasia looks like normal tissue, easy to distinguish from cancer, but stromal hyperplasia and carcinoma in the transition zone look very similar. And this means that our performance for imaging for transition zone tumors is going to be more limited than for peripheral zone tumors. So we're going to have to really raise the bar a little bit, or lower the bar, excuse me, and say that we're looking for larger tumors there. So here is the ADC values for cancer, stromal hyperplasia, and glandular hyperplasia. And when you look at this ROC curve, to achieve a specificity of 80%, we're getting a sensitivity, just if we just use ADC cutoff thresholds, of around 60 to 65%. Now for larger tumors, this doesn't include size. I think we do better than that. And I'm going to show you what these tumors look like. And so for this, we rely very heavily on T2 weighted imaging combined with the ADC. But really, it's the look on T2 weighted imaging that really helps us. So I'll challenge you to say, look at these two different patients. Both had PSAs well above 10, high PSAs, and prior negative biopsies. Both had more than 2 prior negative biopsies. Where's the cancer? And so in both these patients, this is where the cancer is. And what this looks like, and I like this description, is it looks like if this was a charcoal drawing, someone took a wet thumb and sort of smeared across that area. The texture is very different. Both the directed biopsies in this patient came up with higher grade, high volume disease. And I don't think this would have been picked up easily with routine transrectal biopsy. I will say that there is an argument for doing deep non-selective biopsies or non-image guided biopsies, so you say take a longer needle or push in further with your random biopsy. Incremental yield in our experience there has not been great. Transperineal anterior directed biopsy yields have been good though. So if you've got a setup where you say, okay, well we have OR access, we can do transperineal biopsies for these, that's another approach to these. I've had a few anecdotal TURP cases with these. It seems like in a significant number of, again, it's anecdotal, so 2 or 3 patients where PSA is 40 and they've done a TURP, that still the anterior tumor, the cleavage for the TURP seems to sit just behind the tumor, and so it's you look at the post-TURP MR and that tumor is still sitting there. So you don't always get it with a TURP. So I think the transperineal biopsy, if you're not a fan of imaging, and certainly with imaging we can hit these. Here's an example of why the multiparametric is important. So this is a patient who's got a dirty prostate, like the peripheral zone doesn't look normal, it's all gray, and this is not unusual, particularly in patients who've had prior bouts of prostatitis, or just as you age, the prostate gets like this. And what we see with ADC, we can now clearly identify, and with this DCE MRI analysis, an anterior tumor. So a definite tumor. Again, this was a prior negative biopsy patient, directed core, Gleason 3+4, 70% of the core positive. What about the patient experience? So that's sort of the backdrop of imaging. What's the patient experience? So we ask patients to empty their bladder before they get on the table. No sexual activity for 48 to 72 hours. That's so the seminal vesicles are filled, so we can assess stage or seminal vesicle invasion better on T2 weighted imaging. We need to have an empty rectum, even if they don't have an endorectal glow, because gas really interferes with the diffusion weighted imaging. Endorectal device is optional at 3T. I think at 1.5T, you're definitely, in my opinion, cutting your sensitivity for smaller tumors. That may be okay. It depends on your practice. So I think you can do a good job at 1.5T. Exam time is, we do 45-minute bookings with 30-minute exam time for non-endorectal coil, and we do 1-hour bookings. So there is if you've got long waiting lists, there's a strong argument for moving away from endorectal coil in terms of both cost and throughput. This is what the current endorectal coil design looks like. It's a latex balloon. Latex allergies are an issue. There's definitely, I would say, a cultural difference in acceptance. Some cultures, I would say, they just don't want this done. Others are more accepting of the device insertion. But we have used it for years, but we are moving away from it because of the cost and wait list issues now. Post-biopsy hemorrhage is an issue for MR interpretation, although the publications are varied on this. I will tell you, I'm convinced it's an issue. We like to wait as long as possible from the last biopsy. So the wait list in this scenario, where it's assessment after a recent negative biopsy, is not a bad thing. 8 to 12 weeks I like to wait. It still causes problems even that far out, but the longer the wait, the better in that scenario. There's a recognition in the radiology community now, so we've talked about the patient experience. What about reporting, radiologists being well-versed in how to do this? How are we going to bring this out to the radiology community? And so this is a consensus paper that was recently published in European Urology. There's a follow-up in European Radiology with more detail. And there's a recognition that we need to develop standards. And so a key part of this is a scoring scheme, the recognition that it's not a black and white cancer or no cancer. We need to talk about suspicion of cancer and interpretation approaches, zone-specific interpretation are all important. We really like to get the prior biopsy results from you, and so I think this has been an issue with the referrals in terms of, rule out prostate cancer. It's not enough. I mean, I can do the interpretation, but it's really hampering me in terms of giving you the specificity you want. So we really like to have a copy of the prior biopsy report, there's history of prostatitis, what the clinical scenario is, and so on. The current scheme being proposed is too complex, the PIRAD scheme. We're working on paring this down with consensus groups. But I think this brings to the forefront sort of one of the key issues in the reports, is how do we convey to the urologists where the tumor is with a current reporting approach? Are the urologists going to come down and look at every MR, or we have to teach them how to interpret every MR that we're doing? So we need some way of conveying this information. One approach that's being taken is to develop a more detailed division scheme within the prostate. And one of the key things here is this line. This is an 18 millimeter into the prostate line, where most of the time the needle doesn't go for transrectal biopsy. So you know that you've got a deep tumor past that 18 millimeter mark for your biopsy if we identify this. And I'll show you what one of the clinics I'm working with, what kind of report we're generating. So this is what the report looks like. I actually put screen captures on the report for this as well. And so I identify the number of candidate tumor sites. If there's more than 3, I usually don't go into a lot of detail for more than 3. I don't think it's relevant. But I will just say that there's other potential sites. I'll give a probability of cancer, a size, give their locations on this chart, and then give those added screen caps. This is a 1.5T non-endorectal coil image. And you look at this, the peripheral zone looks okay. Hard to see what's going on in the transition zone, but when you look at the ADC map, very clearly an abnormality. You go back, you say, yeah, the texture here is a little smudged. I really need these two to be confident about that. I don't think I would be so confident with this alone. There's a bit of a bulge here. I don't think I can stage that accurately with this, say, is that extra prostatic or not? For that, I really need high-resolution imaging with an endorectal coil, I think. So I undercall for staging on this, and this is the report that goes out. So one definite tumor site, quite big. Those are the zones involved, and then a detailed description. with the sensitivity number for extraprostatic disease given in the report. So I think this hopefully provides enough information for you to direct biopsy and to know what to do with the patient. What's the data on improvement of biopsy yields? It's pretty good. I think positive predictive values are running in the 40% range in patients with prior negative biopsy, 50% in other series. In our hands, in this scenario, I think in Canada the PSA ranges are much higher. Because of the long waiting list, the urologists are selecting out patients with higher PSAs. Our PPV rates are running around 80%. But I think that's a function of having a lot more higher risk patients because of lack of access. This is an MR-guided biopsy approach. I reviewed with the residents a paper that was an ultrasound MR-fused approach with also very good results. I won't be presenting that here, but I know Samir has put together a nice summary of that. And then when you look at where the cancers are positive, it's exactly what we'd expect. And so the hotter colors are where the biopsies were positive. So anterior, central, posterior areas that are not normally sampled as part of the routine are where a lot of these biopsies were positive. So here's a case, patient entering onto active surveillance. Here's the MR. Bottom line is all contrast enhanced assessment. Top is T2 and ADC and diffusion, and there's a tumor right here in the peripheral zone. So there it is. Here it is on the perfusion map. Here it is on T2. And we then go through a process. This is with the Artemis System. Trace the tumor on the MR-based interface. This gets fed into the ultrasound. The operator then traces the prostate after a 3D scan. A little robotic arm does this. And then we get this fused image registered to the MR. Right now this system does not show you the MR at the same time, which is a weakness in this system. The manufacturer is putting this in for us. And then we do the biopsy and we actually get a map of where the needles were. This was a relatively small tumor, and I'll show you the path result in a minute. This is Dr. Malo who does the biopsies. This is the other system that we're using and the one we currently favor because it's very fast. It takes about 3 to 4 minutes to get to a target. And this is a standard ultrasound image from a Philips IU-22, and this is the UroNav system. This is the one in use with the NIH. I don't know if this video will run. Probably won't. No, okay. But this is the MR fused on top of the ultrasound, and Laurent's able to hit these very, very quickly now. And I'll show you some of the results for those. So that patient, the one I showed you with the Artemis, had Gleason 6, 40% core positive. This was a substantial increase in tumor volume on the biopsy compared to his initial active surveillance biopsy, which was a microfocus. Here's another case, high PSA prior negative biopsy, 56-year-old, so a young patient. This was a non-endorectal 3T image. And what you see here is a large tumor right at the apex, right anterior to the urethra. This is an area almost never sampled. It tends to be painful for the patient when you fire the needle in this area. This patient had, I think my path results slides, but this patient had both cores positive targeted in this area with Gleason 3+4 disease, and so clearly needs something done. Important that the urologists know that this is right at the apex, right near the sphincter in terms of planning a potential surgical approach for this. It's really right on the sphincter. I mean, this is the sphincter here, this dark ring. So it's sitting right on top of the anterior aspect of the sphincter. So for continence and so on, this may affect the approach taken to treatment. So what are our results? And we're now up to about 65 patients in a cross-sectional prospective trial. This is with Lori Klotz at Sunnybrook. And the protocol here is to do patients who are getting biopsy for cause on active surveillance. So either entrance biopsy, 3-year biopsy, or rising PSA. And what we've shown is that the trial design is to do 12 cores by one operator and at the same sitting then do targeted cores identified with MR using that interpretation scheme. And what we've shown is that overall in the patients, some patients we don't do any targets, that the mean cores are 2 versus 12, so we're getting away with a very low core count. 20% of patients have had actionable tumors missed on the 12 core. And so far, we haven't missed a Gleason 7 case in even up to 65 patients. I think this will change. I think we'll get this number will come up to about 10% as we move on in terms of missed tumors compared to the 12 core. But having said that, we're very happy with these results. And this is with ultrasound MR fused biopsy using the Euronav system.
Sorry to interrupt.
Yeah.
How do you know? What's your gold standard?
So the gold standard here is the comparison with the 12 core, which was what the patient would have had done. So this is not a true sensitivity specificity assessment. This is an assessment on sort of what the potential miss rate is when comparing to 12 core and what the potential incremental yield is when compared to 12 core. So what we're showing here is that we're not losing much compared to a 12 core, but we're finding tumors. And I think the consistent message coming out of these trials is that first, you're not missing very much. Second, you are, despite cutting the core count substantially, actually picking up disease missed on the 12 core. So we're doing well on the sampling problem. And in those healthcare systems where the cost is, there's a per core cost. So in the U.S., many states, the pathologists charge more the more cores you do, and it's not a small amount. So when you start to look, and people are advocating 17 cores in this scenario or 18 cores, and you say, well, we can get away with 2, a mean of 2 across the population, and still pick up more tumors and not miss anything significant. I think that's sort of the message of this data. But in terms of then saying, well, what did they actually, on follow-up, what happened to these patients? Of those that got radiation, or did we change the outcome in active surveillance in these patients? This is the big question, and I think we'd love to show that in a randomized trial that there. And so there is a randomized control trial underway. That's a 2-step trial. The first step, and what we have funded, is called the ASSIST trial in Ontario, 3 centers, and this is Laurie's the PI on this. Is to actually have one arm where they just get the biopsy on entrance onto active surveillance, and the other arm where they get a biopsy with MR guidance, and see if we can what the Gleason score upgrading is in the 2 arms. And then we want to take those patients, obviously, and follow them and see what their outcomes were. So, that's a long answer, but I hope it answers your question. So what about staging? So I've talked a lot about localization. Staging, this is what big, ugly cancers look like. And so I've already gone through some smaller cancers. So big cancer here, invasion into the seminal vesicles, T3B disease, not hard to diagnose. Another case of seminal vesicle invasion. You see the benefit of having the seminal vesicles filled here. So tumor going right up into the left seminal vesicle, and in fact a little bit of tumor here coming out on the right side. A lot of these patients with very high tumors, are DRE negative. So I think MR is helpful in these high-risk cases or high intermediate risk cases. Here's an example of gross extension outside the prostate, Gleason 9 disease. This patient went under radiation. Here's Gleason 8 disease, and there's a little bit of extension here extraprostatically, but a lot laterally. And this patient was DRE negative. Had nerve-sparing surgery on the left, but not on the right. So I think planning surgical approaches here is certainly one thing that some of the urologists appreciate. How to interpret these? This is, I think, the view of many of us in the community with prostate MR, is that the radiologists should be interpreting these with a high specificity approach. So when you look at the published data going back decades on this is the problem, is that the performance for staging with MR is all over the map. We want to be up here somewhere to make this, in the cost-effective analysis, to make this worthwhile in terms of moving patients away from surgery who really shouldn't have it. We need to achieve sensitivities of at least 60% while maintaining specificities of 80%. So these are the signs. I won't go through them, but I would say that the current data is, number one, that there is incremental benefit over the base model for extraprostatic extension. This data has been duplicated in a number of studies, but this is retrospective data from Memorial, looking at T2 and spectroscopy. The real incremental benefit is in the intermediate and high-risk patients. This really shouldn't be done in low-risk patients. Staging. We don't do a lot of staging in our practice, but I think if you're going to do it, you don't want to stay away from the low-risk patients. And this is sensitivities of around 64%, 3T with endorectal coil is where we sit. So if we call extraprostatic disease as radiologists, it means our certainty level is very high. But if we don't call it, then there's a chance the patient does have it, but we just can't see it. Nodal disease, we don't have a breakthrough yet for nodal disease. There was a lot of excitement about one agent. It never got through the FDA, Combidex, and so this is sort of petered out. PET scanning, there's still work to be done there in terms of getting an agent that will pick up small nodal metastasis. And that's sort of what we're after. The big ones is generally not a problem right now. This is some of the data, and this has been duplicated in another study from UCLA talking about surgical plan alteration in terms of nerve sparing, sphincter sparing surgery, showing that MR does have incremental yield, better than the clinical assessment of what size you think the tumor is and how extensive it is in terms of planning surgical plans and resulting in negative margins. So if negative margin is the outcome, then it's helpful. So let's get into some of the research. So focal therapy, I've got another just 10 minutes, so maybe I'll keep this to 5 and then leave time for questions. So this is just a summary of some of the data I showed in this concept of the index lesion. So this is very important. It took a while. We saw sort of the attendance at the focal therapy meetings go from a few people there to tell you you're out of your mind to some real engagement over the years, and I had the privilege of being at some of these meetings, not many, but some, to see sort of the temperature of this, and the acceptance in the urology and radiation oncology community has really, really improved with this idea of if we treat the dominant lesion, we're potentially doing something additive. And it seems like, particularly when you look at patients with lower PSA, that in fact this idea of this dominant tumor being the source of extracapsular extension holds better. And so exactly the patients we might want to target with focal treatments are the ones where this paradigm seems to potentially hold up. But when we're doing imaging, we're used to this idea that what I see on imaging is what I'm going to get at pathology, or at surgery. And what we were starting to find is that this isn't true. When you look at imaging, so this is a case I will tell you there's really nothing to see here on the MR. But the pathology we got back was this big cancer. So why am I missing such a big cancer on MR? And what we found is we sat down with our pathologists, and we found in fact that the stroma in the prostate and the distribution and density of glands within the prostate had a huge effect on what we saw on MR. And this has never been really assessed by the pathology community. They focus on Gleason score, but we don't know what the prognostic implication is if you have multiple malignant glands dispersed throughout the gland as opposed to all sitting in a nodule in one area. And we found when we started to map these tumors, these white areas are these sparse areas within tumors, is that these are all different patients, a substantial number of patients had subregions within their tumor that were sparse. The good news is that these are almost always Gleason 3 pattern. But it's something to consider for focal therapy, is that MR alone, if you want to eradicate the entire tumor focus, including the Gleason 3 components, is not going to be adequate to draw a boundary. You need to put a margin on. You need to make a decision whether Gleason 3 for you is important in this paradigm of focal therapy. Why are we using MR for focal therapy in our practice? It's because of MR thermography. This is data from a Visualize software. This is a commercial system. And you can actually watch these temperatural and thermal damage maps grow in real time as you turn this thermal laser on and know when to start and stop treatment. And so this is John's team, which I'm a part of, has been doing this at UHN for a while. This is what we do. We have in-house software, define the tumor based on multiparametric imaging. So I do these tracings on the software. It's a transperineal approach for delivery. We were using a template for a while. We have other sort of devices now that we use to deliver the laser fiber. The laser fiber goes in like this. That's what it looks like on the MR. And then we'll proceed with the thermal burn once we're happy with the location. And then we do a post-contrast assessment to demonstrate the the thermal damage, and then we map this back to, this is the earlier work on doing the pathology mapping. We get nice contiguous burns, and we're able to see what % overlap we get. There are a variety of systems being prototyped and developed. This is the Hologic Sentinel Table that's MR sort of designed to deal with this issue of bringing the patient out without moving them, so you can insert the fibers and put them back in. This is the EXA Blade System from Insightec. We have one of these prototypes. This is Dr. Guy with John Trachtenberg has done a couple of patients now. And this is a very interesting system from Sunnybrook where we're doing our first patients. This is Laurie Klotz here, and I do all the tracings for this. This is the transurethral device. This has now been commercialized or put into a commercial form with a company, and there is a trial planned in the U.S. So the urologists insert this device. It's about the same diameter as a little less than a cystoscope. But this is the cool part, I think, is that you don't. What happens is this is real-time feedback MR thermography. So, oh, forgot to check this video. Shoot. What I was going to show you here is that this boundary is what we are. This has just been published in Radiology. If you look in the last 2 months, just come out. This is the phase 0 sort of feasibility testing. So this is the boundary we wanted to treat. And what happens is the speed of rotation of this focused ultrasound device and the amount of energy it delivers will change based on this imaging data. So this gets fed back into the motor, the MR-compatible motor, and the speed of the device, the rotation of the device changes as the 55-degree thermal boundary is hit. And the path data on this is really good. So this is sort of this real-time feedback loop and controlled burn. And in fact, the prediction of the burn with pathology is better with the thermography than it is with the post-contrast assessment. And so this is pathology showing the necrosis, the penumbra. This is coagulative necrosis in here. And we're doing really, really well in terms of defining this. So the errors here in the order of a couple of millimeters with the predicted boundary. So meticulous, this is a human prostate, not a dog or anything. Meticulous correlation has been done, RadPath correlation, to demonstrate this. And so the feasibility study has been done, completed, published, and we're now moving on to intent to treat trials. And this is sort of the process, is that you have the option. So what's been the big criticism for focused ultrasound and HIFU? It's the time. These things take hours to treat the whole gland. To treat that target volume area, the CV, where the cancer volume, we're looking at about a 6-minute treatment. To treat the entire gland, 20 to 40 minutes. So this delivers a lot of energy in a short period of time. And so this is why I think this is a very attractive technology compared to the Ablatherm and EXA Blade technologies, is that you're not doing spot burns. And the data on the whole mounts has shown that the burns are contiguous. So this idea of potential viable tissue between each gap as a potential weakness in the spot HIFU-based approaches is overcome with this. We still don't know whether we can reliably get right out to where a lot of the cancers sit, which is just deep to the capsule at the margin. So I'm being very honest here. We're anxious to see whether we can do this. And I think we're still in discussions about whether we want to, at the same sitting, treat as much of the rest of the gland as possible while sparing the sphincter and urethra, or whether we just want to go for one focus and then have the patient come back if necessary. So these are all things that I think we'll take a stepwise approach to. But this is, I think, for me, a very interesting piece of technology. So where are we now? Well, we're overflowing with referrals. We need appropriateness criteria. I think we really have convinced the urologists. I mean, when I moved to Sunnybrook just part-time to get a prostate program started there 3 years ago, I will tell you that the urologists were skeptical. The quote I got from Laurie is, "I've drunk the MR Kool-Aid." He said that last week. So he's I don't know how much of a believer he is, but at least he's on the step there. Better prognostication, I think we're starting to demonstrate that, I think in particular in the active surveillance group. And certainly the radiation oncologists, our urologists, and I haven't showed slides of salvage scenarios as well. We're getting referrals for all of these now with the focus on therapeutics. So that's where we are today. Thank you very much.